In this class, we are going to discuss about hemochromatosis. Hemochromatosis. What is this hemochromatosis? This is the most common inherited disorder. Inherited disorder where there is an increased iron absorption through intestines, and this absorbed iron will get deposited. That means excess iron will get deposited in the cells of the tissues. This deposition will cause organ damage, and this organ damage will cause loss of organ function. And this hemochromatosis is classified into hereditary hemochromatosis and acquired iron overload. In hereditary hemochromatosis, there will be an HFE hemochromatosis, which is called as a type 1. Okay. Next, there is non-HFE hemochromatosis. One is, it is classified into different types. Okay. Juvenile hemochromatosis type 2A, which is due to hepcidin mutation, and second one is juvenile hemochromatosis type 2B, which is due to hemojuvelin mutation. Next one is transferrin receptor 2 mutation, which is type 3, and there is ferroportin mutation, ferroportin 1 gene mutation, which is a type 4-1. So this hereditary hemochromatosis is divided into HFE and non-HFE. In non-HFE, we have 4 types. Next, in acquired iron overload, this can be caused by anemia characterized by ineffective erythropoiesis. What happens in this? There is an anemia. Due to anemia, the hemoglobin formation is less, and this causes stimulation of it causes increased absorption of iron into the body. So this causes iron overload. This condition is seen in thalassemia major and sideroblastic anemia. And repeated blood transfusions will cause iron overload. And next is parenteral iron therapy, which is given for an anemia patient, that can also cause iron overload, and dietary iron overload. In African countries, they'll cook food in iron utensils, and this can cause increased iron levels in the body, increased iron absorption, and this is called as Bantu siderosis. In an African tribal area, you will see Bantu siderosis, where they will cook food in iron utensils. And there are other conditions which are not directly related to the iron, but they are associated conditions which will cause increased iron overload. Okay, other conditions like alcoholic liver disease, non alcoholic steatohepatitis. Third one is HCV infections, hepatitis C, viral infections, and porphyria cutanea tarda. This is one type of porphyria where it will cause iron overload. All these conditions are not directly related to iron, but these diseases will cause increased iron overload in the body. We'll see individual mutations. Okay, individual mutations. First, we'll see HFE hemochromatosis. First one is HFE hemochromatosis. Normally, iron is transported with the help of transferrin, and iron is present in a transferrin. This is transferrin. This is called as holotransferrin. And at the tissue level, we have transferrin 1 receptors. Normally, HFE will bind with the transferrin receptors. They are together. Whenever holotransfer is coming to the tissues, it will compete. This holotransferrin will compete with HFE for binding with TFR1 receptors. Okay, that means HFE is thrown out. What will happen? This displaced HFE is displaced from TFR1. This displaced HFE will go and bind with transferrin 2 receptors present in liver. These transferrin receptors will help in synthesizing hepcidin. What this hepcidin will do? It decreases iron absorption. This is the normal thing which will happen in a person. But what happens in HFE mutation? If this is mutated, then this will not cause synthesis of, this will prevent synthesis of hepcidin. This is mutated HFE will prevent synthesis of hepcidin. If hepcidin is not synthesized, then what will happen? This will increase iron absorption. This mutated HFE will decrease hepcidin, which will cause increased iron absorption, because a hepcidin will bind with the ferroportin and it will prevent increased flow of iron into the blood from the basolateral membrane of an intestinal cell. If this mutated HFE decreases hepcidin synthesis, then iron absorption cannot be stopped. That's why they will cause iron overload. Next, this HFE mutation is commonly seen at the 282 position, where there is substitution of cysteine to tyrosine amino acid will occur. And one more mutation is at the 63rd position, where substitution of histidine to aspartic acid will occur. Histidine to aspartic acid will occur. And this mutation is an autosomal recessive one. Autosomal recessive condition. This is rarely severe before fourth decade. Rarely severe before the fourth decade. And next is hemojuvelin hemochromatosis. Hemojuvelin. What happens here? We have a bone morphogenic protein, BMP, and at the tissue level we have BMP receptors, and along with the BMP receptors on this side we have a co-receptor called as hemojuvelin. This bone morphogenic protein will bind with the bone morphogenic receptor along with the co-receptor and causes activation of SMAD protein. This SMAD protein will cause increased hepcidin. If this is a normal process, whenever there is a mutation in hemojuvelin, then this SMAD cannot be stimulated. If this SMAD is not stimulated, then mutated hemojuvelin causes decreased hepcidin synthesis. Mutation of hemojuvelin causes decreased hepcidin. If hepcidin is decreased, then increased iron absorption will occur. This is one thing. Whenever ferroportin is mutated, this is an intestinal cell. Here we have a ferroportin. Whatever iron is absorbed through DMT1, this has to pass through ferroportin. If ferroportin is damaged, it can't be regulated with the hepcidin, and directly iron will be absorbed into the blood and it causes iron overload. This ferroportin will be regulated by hepcidin. And if there is a mutation in hepcidin also, it will not regulate iron absorption. Next, what will happen clinically in these patients? These are the different types of hemochromatosis which you will see commonly. Commonly mutated HFE mutation hemochromatosis is seen. After that, non-HFE related hemochromatosis is seen. Acquired causes of hemochromatosis are very uncommon. Okay. Next, what clinical manifestations the patients present with? The first organ or to be affected is liver. Most commonly, liver is the usual organ to be affected. What will happen when liver is affected? Hepatomegaly will occur because iron will be deposited inside the liver and it causes hepatomegaly. This hepatomegaly is seen in 95% of symptomatic patients. And this hepatomegaly in the long run will cause portal hypertension and cirrhosis. Portal hypertension and cirrhosis. On longer term cirrhosis will cause hepatocellular carcinoma. Hepatocellular carcinoma. This hepatocellular carcinoma is seen in 30% of patients. 30% of patients. 30% of patients with cirrhosis. Normally, 95% of symptomatic patients will have hepatomegaly, which causes portal hypertension, and longer term of cirrhosis will cause hepatocellular carcinoma. That means this hepatocellular carcinoma is seen in 30% of patients with cirrhosis, and it is the most common cause of death in treated patients. So because of this, early diagnosis and treatment of hemochromatosis is very important. The incidence is greater in men than women. Okay. Next, this is about liver manifestations. Then skin. What will happen in skin? There will be increased pigmentation. There is an increased pigmentation, which is like slate gray hue color will be there to the skin, and this is called as bronzing. Why this bronzing occurs? This is due to increased melanin and iron. These are both deposited in dermis. Next, this pigmentation is diffuse all over the body. It will appear all over the body, and it is generalized. And you can see this pigmentation in scars also. This is about skin manifestation. Next is pancreas. What will happen in pancreas? There will be direct damage to beta islet cells by iron, and it causes diabetes mellitus. And it can also increase insulin resistance. And with the long-term diabetes mellitus, you will get complications of diabetes mellitus, like nephropathy, neuropathy, and retinopathy. Complications of diabetes mellitus. Next symptom is arthropathy. It is seen in 25 to 50% of symptomatic patients. It occurs after 50 years of age. Next, which joints are most commonly affected? Most common affected joints are second and third metacarpophalangeal joints. And in long-term therapy, long after the therapy, this may be the first manifestation. Arthropathy may be the first manifestation. In a treated patient. This will appear mostly after 50 years of age. And this arthropathy progress despite removal of iron by phlebotomy. Okay, this arthropathy will proceed even if you remove iron by the phlebotomy. Next involvement is cardiac involvement. What will happen in cardiac involvement? It is seen in 15% of symptomatic patients. And most common manifestations in the cardiac is congestive heart failure. And the symptoms of cardiac failure or congestive heart failure, they will develop rapidly and they progress to death if untreated. They are untreated. And they can get supraventricular tachycardia, paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillations also. Next, hypogonadism. This occurs in both sexes. They will cause loss of libido, impotence, amenorrhea, testicular atrophy, gynecomastia, sparse body hair. These are the symptoms which are seen in the hypogonadism. In the next part, we will see with the diagnosis and treatment. Thank you.